station or a doctor got bedside and took over. It was never designed for the back of the ambulance. So it doesn't translate real well. Yes, if you were in a hospital and you can call the pharmacy and you can get procainamide, you can get Sotalol, great. But that's not something we carry in the EMS world. We carry what options? Amiodarone and lidocaine. When you actually go through the back part of the book, or you use what's actually called the guidelines, which is what they created that shortcut ACLS off of, it says that lidocaine can be used for VTAC. So that's the problem I have with those flashcards that come out of the ACLS book, and that's the problem I have with the ACLS, is it doesn't translate well to what we do in the field. Think about all the things that are in that book that we don't actually carry. Think of all the things that aren't part of our drug list that are in that book. And it's not just because we don't use it in Viatel, but a lot of that stuff is not pre-hospital at all. All right? Like a CAT scan. ACLS talks about you taking a CAT scan and diverting an ambulance. Are we going to do that when we're on the ambulance? So that's the problem we get into. So just, I understand what you're saying, and I appreciate it. Just keep it simple. Just keep it simple. If you get so much extra data in your mind, it's going to blow you out of the water on the test. All right? Keep it simple. This will get us through what we need next week, and this will get us through the registry. And this is way more than you need for Viatel. All right? So just don't put that information in your head. Reality is, you guys are going to have about 1 to 5 drug questions total on the registry exam. That's it. You're going to have 1 to 5 drug questions. You're probably going to have a cardiac question or two. Most of the cardiac questions are probably going to be electricity, because they want to recognize or test you that if you know they're unstable, you go straight to electricity. You're going to have 1 to 2 that are electricity. You're going to have 1 to 2 that are worded with a refractory. You're probably going to have 1 that's related to an overdose, 1 that's related to airway, and then 1 that's related to cardiac, chest pain. If they ask you a super hard drug question and you get it right, they're not going to ask you anymore. So for example, if I said you have 17-year-old female severe asthmatics, refractory to albuterol, Atrovent, and epi, what's your next option? And I list Solumedrol, MAG, lidocaine, or Lasix. MAG. You get that question right, they're like, dude, the guy knows you can use MAG for refractory asthma. He probably knows his torsades. He probably doesn't need more drug questions. If I say you got a 56-year-old male actively seasoned, you should give amiodarone, atropine, Ativan, or lidocaine, and you pick lidocaine, here we go. And that's the way the test adapts. And so that's why a lot of kids have 1 to 3 drug questions, and they're like, man, they're pretty cut and dry. If you don't get those cut and dry questions right, it's going to open the gate, and they're going to hammer you on a topic. All right? So don't put all that bizarre. The registry's not, there are some pilot questions that ask random stuff, but for the most part, the registry is designed, can you get 70 to 80% of the meat and potato stuff of being a paramedic correct? Can you get the amiodarone for VTAC? Can you get the lidocaine for VTAC? Can you get atropine for bradycardia? Can you get pacing for bradycardia? They want to see that you can do the meat and the potatoes of the job. There's no reason for me to ask you the bizarre shit if you can't do the basics. And that's why there's not that many drug questions on there, and the ones they ask are pretty cut and dry. Unless you do really well, like the first 10, 15, 20 questions, you just ace that shit, they're going to throw random shit at you to gather data. And most of those questions on your test aren't going to count after that. You can literally, in the first 20 questions, pass that test, and then it throws stuff at you to gather data for future tests. And usually what I find is the more weird and bizarre the questions are, the better that kid did on the registry. Because basically they went in the first 10 to 20 questions, they knocked it out of the water, and they're like, well, he's proficient and everything. Let's use him to see about these random shit that's out there to see what actually is being taught. And that's why there's pilot questions on there too. So now you go to 130, 140, 150, you're probably not seeing any random questions.
What if they're all random?
Tomorrow I'll break down a little bit more how that computer actually is set up to grade and adjust the difficulty of questions. But for the most part, if you get cut off at 80, you kicked its ass or it kicked yours. There's no in between. You either really passed it or you really failed it. If you go 80 to 110, really about 90 to 110, you probably struggled in a couple areas, but you probably passed. If you go 130 to 150, you barely passed or barely failed. It's that cut and dry. Most students fail the registry by less than 10 total questions, which is why we need to pick up 10 off our dry erase board. All right, when we actually look at the data, and we'll break all that down. All right, but back to your point, don't worry about the bizarre stuff. Did you ever hear anybody in the classroom when we were doing dynamic, static, or lectures mention Procana or state law? Then don't worry about it. All right, it's not that we're being idiots and not knowing about it. It's we're intentionally leaving it off because you're not going to see it. It's not going to be in the registry, and we don't want it to enter your mind and confuse you. And that's the problem I have with those ACLS flashcards is they're not designed for us in the hospital. I wish they would create a paramedic-only ACLS book. The problem with the paramedic-only ACLS book is there is no rules when it comes to paramedicine because it's all about who you what.
Who you work for?
Yeah, your medical director. Your medical director gets to decide how and what drugs you give. Our medical director gets to decide that a diabetic blood sugar is 110, whereas National Registry is 80 adults, 60 kids, 40 infants, and we have a 80 and 110, are they diabetic or not? We have all these random numbers because one time at band camp, a UT Southwest doc saw hypoglycemia in a patient that had a blood sugar of 112, so everybody's got to think about that now. Whereas the registry goes, 80 is the accepted number for most places except Viatel, 60, and that's why it's written. All right? Unstable, chalk them first. Cardiovert. Now, why do we cardiovert?
To get their rhythm or try to knock their rhythm back into place.
What is happening during the QRS? The sodium potassium is what? Moving.
Yeah.
So by cardioverting, what's happened is it's marching out the difference between the R and the T, where the sodium potassium is moving, and it's not delivering electricity between that point, because if it's half in, half out the cell, and the electricity hits it, it will put them into V-fit. This is what's called the R on T phenomenon. What blunt trauma will cause them to go into V-fit? Commotio cordis, which is that perfectly timed line drive to the chest, football tackle to the chest, punch in the chest, where between the R and the T wave, the sodium potassium we're moving gets that outside influence, makes it dump, and puts them into V-fit. So when we sync cardiovert, we're measuring that R to T to where we avoid delivering electricity when the electrolytes aren't in the correct spot. That's why we sync cardiovert. When they're dead, we don't care where the electrolytes are because they're already in V-fib or pulses V-tac. That's when we defibrillate. That's the refractory period. That's correct. And we don't want to stimulate them during that, right? Because if you put them in a V-fib. That's why we sync it. That's why we have that dark spot on top of the QRS when we hit the sync button. That's why when you hit the sync button and you hold down shock, sometimes there's a delay. Sometimes there's a 2-3 second delay. When we used to do manual, I would see guys, they go clunk, clunk, and then they'd be like, and when they raised up, it'd finally deliver, and then it would spark and end up burning the patient. Because what they weren't realizing is even though they're holding shock, it is trying to find the perfect time before it finally delivers it, and that's why there's a delay in it. Versus defibrillation, you hit the button, it goes immediately. So that's why we have to sync it to avoid that R on T. So that's why we're cardioverting these patients. Cardiovert, amiodarone, lidocaine, if all else fails, you could try MAG down the road. All right? Good on that? Bradycardia. This one's a little bit more difficult because in order to be bradycardia, we have to rule out all the other causes of bradycardia. All right, now, when we do our bradycardic algorithm, it doesn't necessarily differentiate between first degree, second degree, and third degree blocks. It just says bradycardia. So here's what we have to rule out first. In order to be bradycardic, it has to be electrical in nature in the heart. If I have a heart rate of 36 and pinpoint pupils and respirations of 6, that is not bradycardia. That is a what?
Opium.
Opiate overdose. They don't need atropine. They need what? Narcan. If I have dilated pupils, heart rate of 42, respirations of 6, and a suicide letter with an empty bottle of Xanax, that's not bradycardia from the heart. That's a benzodiazepine overdose. Benzos will make the pupils dilate. What if there's an empty bottle of amitriptyline, nortriptyline, or Elavil?
TCA.
Those are TCAs. What's the antidote for that? Bicarb. What if there's an empty bottle of Betalol? That's a beta blocker. What's the antidote? Glucagon. What if there's an empty bottle of Cardizan? A toddler gets into grandma's Cardizan and he's bradycardic. Mag would slow it down. Calcium chloride. Or how else do you treat beta blockers? We start with glucagon. Calcium channel blockers, we start with calcium chloride. Cardizan would start with calcium chloride. So we want to make sure it's not hypothermia, it's not an overdose, it's not a head injury prior to going down the bradycardic algorithm. All right? We've ruled out all the other causes. Once we've ruled out the causes and it is cardiac, we're going to look at atropine, 1 milligram a minute to a max of 3. That's a January change in ACLS. Instead of being 0.5 to 1, it is 1 now. Okay, they went back to 1. So 1 milligram, max of 3, pace, dopamine drip at 2 to 20 mics per kilo per minute. If that doesn't work, epi drip, 2 to 10 mics per minute. Now, in second and third degree blocks, the atrium is firing, but the electricity is not moving in a coordinated effort to the ventricles. So what drug is probably not going to work in your second and third degree blocks? Atropine. So in your second and third degree blocks, a lot of times they're going to make their pressure extremely low to where we go straight to what? Pacing. All right? If you got a blood pressure of 60 and a third degree block, first of all, is atropine going to do anything for a third degree block? No. Second of all, with a pressure of 60, is it even going to be transported through the system? So a lot of times in your second and third degree blocks, they will make them so unstable and so sick that we go straight to pacing. All right? If the pressure's in the 80s and it's not a second or third degree block, then you can start with atropine. All right? So this one's kind of a little different as far as you're going to have to look at the overall blood pressure and whether it's a block or not to determine do we start with atropine or go straight to pacing. Static, just rattle off the algorithm. Computer test. This one I saw a couple of weeks ago on the registry from a kid. It gave him this. 62-year-old female, unresponsive, heart rate 32, blood pressure 60 over 40. You should administer amiodarone, epi, drip, 2 to 10 mics a minute, lidocaine, adenosine. Well, first of all, rate is too what?
Slow.
Slow. So the rhythm's probably bradycardic of some type. And then blood pressure. Rate slow, blood pressure's low, She's unstable bradycardia, correct?
Right.
Unstable bradycardia, I would try pacing, not a choice. I would try atropine, not a choice. I would try dopamine, not a choice. What's part of my algorithm? Epidurel. Amiodarone, lidocaine, Denison are all going to slow it what? Down. She's already slow. Yeah, but it didn't say atropine. Okay. Man, I really wanted pacing. Okay, but it's not choice. That's bullshit. Okay. Get your red patch, do your CE, and never take the test again. Or whine and gripe about it and come see me again in a year. Hell no. I heard that. I don't blame you. All right. So the bradycardia is a little bit more complicated. First degree blocks, sinus and junctionals will typically respond to atropine. A second degree 1, second degree 2, third degrees don't necessarily respond to atropine because remember, the atrium, the SA node doing what it's supposed to, but it's not moving through the junction or it's out of sync with the ventricles. And if you give atropine, it just speeds up that SA node, but that's not the problem. The atrium's firing. That's why I had P waves. All right, so that's one of those things. So that's why typically the second and third degree blocks don't make unstable. Real quick review on your blocks. I will draw them as best I can. Basically, if I have a elongated PR interval and everything is the same,
First degree.
first degree. If I start out with the normal PR interval, gets a little longer
Winky Bob.
until eventually I drop one and then the pattern starts all over. Second degree type 1 will lengthen, drop one, and start the pattern all over. A second degree type 2
Be the same. Just drop
looks like a sinus rhythm, and then all of a sudden I have multiple P waves, and it may go back into a sinus rhythm. In this particular one, PR interval's fixed, PR interval's fixed, no QRS, PR interval fixed. This one, if I got more P's than Q's, it's a second degree type 2. You can see a second degree type 2 go sinus into the block, or it can stay a block the entire strip. So for example, you could have like 2 P waves for every QRS, and it never go back into a sinus rhythm. It can occur either way. Bottom line is, for every QRS, if the PR interval is fixed, that's a second degree type 2 or a second degree fixed. Type 2 means Mobitz type 2. They will use all 3 of those on the registry. You may be looking for a second degree type 2 and it says Mobitz 2. That means the same. Or it may say second degree fixed. It means the same as a type 2. They'll use any one of those 3 words. If all 3 are present, you got the rhythm wrong and pick the one that doesn't mean the same. All right? Because they're not there to do that to you. If I give you all 3 words meaning the same thing, you misdiagnosed it. Okay? And then a third degree, of course, basically the P wave's doing whatever it wants to do. All right? The R to R is regular. R to R is regular. If this P wave was here, that P wave occurred there. P to P is regular, R to R is regular, but they don't hold hands. Every once in a while, you'll get one that looks like it should sync up. RN to paramedic study packet. Have y'all looked at that? There is good rhythm pictures of all the rhythms in that RN to paramedic study packet. That thing's pretty good because it has a bunch of different pictures in it. I do need to update the algorithms, but the algorithms on that, with the exception of atropine going from 0.5 to 1, there really isn't any changes worth noting in the new ACLS book compared to what y'all were issued. It's not that big a difference. They didn't change epi. Biotel has a max of 3 epi. ACLS doesn't. It's still every 5 minutes. So there's not that many changes that those algorithms won't work for what we're doing. The changes are so subtle in that thing. Like they changed the compression rate from at least 100 to now it says like 100 to 120. I mean, it's still little things like that to where they could justify selling a new book. The science behind it didn't really change anything. All right. Are we good on SVT versus VTAC with the pulse? versus versus bradycardia. If you were to see polymorphic VTAC, also called torsades, and it has a pulse, would you give amiodarone or MAG first according to registry? MAG, but instead of IV push, you would drip it in over how long? 10 to 20 minutes, just like we did our amiodarone. Amiodarone, they're dead, we pushed it. Amiodarone alive, we dripped it in over 10 minutes. MAG, they're dead, push it. MAG, they're alive, drip it in over 10 to 20 minutes. All right? Let's start on dead people.
Hell yeah.
Dead people are easy.
Shock 'em.
All right? So when we look at dead people, we basically have two options. They're dead. We either no shock or we shock. No shock is our PEA, asystole. Shock is our VFib, pulseless VTAC, and pulseless torsades. Torsades may or may not have a pulse. Just like VTAC may or may not have a pulse. All right? So, PEA and asystole. We're going to start CPR. We're going to get an IV. We're going to give 1 milligram of epi every 3 to 5 minutes. And we are going to consider H's and T's. And I'm going to put airway over here with the question mark. Testing purposes, you do not have to place an advanced airway in the first 6 to 10 minutes of a full arrest. Now, stop and let's think about this. Testing purposes, not real world. Testing purposes, you're a private paramedic on a private ambulance with an EMT. Okay? Your EMT cannot operate the monitor. Your EMT cannot intubate. Your EMT cannot get an IV. And your EMT cannot push drugs. So what is your EMT doing the whole time you were working? 30 to 2. So they're going to go 30 compressions, 2 bag or pocket mask. So that airway is being managed under BLS as part of that EMT doing their CPR. Now, in our system here, if you got an engine crew and you got 3 or 4 paramedics on the engine, and we got 2 paramedics on the ambulance, all this stuff's happening simultaneously. Somebody may be getting an IV or drilling while somebody's dropping a tube or king tube while somebody's working the monitor. It all happens simultaneously. For testing purposes, though, we place more emphasis on an IV than an airway. Right now, knock on wood, my pulse ox should be 99 to 100%. If I was to have a heart attack right now, I still have 100% oxygen in my blood. It's just not moving. So when that person starts CPR on me, they are moving oxygen now. And that is going to, just because of the movement of the chest from compressions, will help move a little bit of air in and out. Intubating me is not going to save my life right now. Starting an IV, giving me Effie, and figuring out why the heck I died as part of my H's and T's will have more of a life-saving effect than getting an airway on me right now. That's why IV is before airway if you are by yourself with the EMT partner, which is how the test is written. Real world, this stuff is going to all take place simultaneously, right? But for testing purposes, an IV. Per Biotel and ACLS, you cannot do an IO until you have done what twice? I've IV twice. That's why I wrote IV there instead of IO. H's and T's, hypothermia, warm them up. Hypoglycemia, give them D10. Hyperkalemia, give them albuterol and calcium chloride, but they're dead. How do I give them albuterol? Run a nebulizer, use the T on it, and put it between the bag and the ET tube or the king tube. Or between the pocket mask or the BVM mask and the bag. You can put albuterol through a nebulizer into a tube. All right? If they have renal failure and they miss dialysis, calcium Chloride, if you find out they overdosed on a beta blocker, glucagon, you find out they were a heroin addict, Narcan. But the first drug prior to any other drug is what? Epi's always first, because they got to prepare the body for the next drug coming in by getting the alpha effects of the epi. All right? If I discover they have attention pneumo, do I have to push epi first?
No.
No, it's a life threat. Fix it.
Dart.
All right? Dart it. The new darting is where? Fourth or fifth mid-axillary is the primary. Fourth or fifth mid-axillary. All right? It's a little bit easier to get to. If that doesn't work, I can still go to the second or third midclavicular, but fourth or fifth mid-axillary is primary now. That's all part of my H's and T's. All right? Do we understand the airway will be managed by the EMT as a basic for testing purposes? All right? B-fib. We are going to do CPR, and we are going to defibrillate at 200 joules, which is 360 monophasic, as soon as possible. So we want to start CPR the soonest we can shock them, the better. After we shock, we immediately resume what? CPR. Then we get an IV, and I'll put airway kind of by itself with the question mark. If we're by ourselves with an EMT, they're just going to be bagging it. They're going to do their 30 to 2. Multiple paramedics, one of them can get the airway at some point. All right? We got to give a drug, 1 milligram of epi, circulate it through good CPR, shock again. On our monitors at the fire department, we can go from 200 to what? 300. Shock again. If this is medical V-fib, what do they need? 300 of amiodarone. Circulate it. Shock again. 360. Resume CPR. Now it's time for another what? Epi. So we went shock, epi, shock amiodarone, shock epi. Circulate it. Resume CPR at shock. Now it's time for what? 150 of amiodarone. Circulate it. Shock again, 360. Resume CPR. Time for another milligram of epi. Circulate it. Shock again, 360. Resume CPR. For Biotel, you can either keep going epi or you can try what? Lidocaine. On the registry, if I said you're working V-fib refractory to amiodarone and epi, what is your next drug? Lidocaine. So I could give lidocaine here, 1.5 milligrams per kilogram. All right? So circulate it, shock again, another epi, always resume CPR after every shock. So up here would be another 1.5 milligrams per kilogram of lidocaine. Circulate it again, shock again, 360, CPR, 1 milligram of epi. Now what? Shock again, 360, resume CPR. What could you try now?
Bicarb.
Okay? Is bicarb going to terminate V-fib? Watch your head.
Yes.
I almost made it. Is bicarb going to terminate V-fib? So what other antiarrhythmic could I try? MAG. Basically, nothing is working. I could try it. You are not going to have to go this far on your dynamic. Computer test. What is your first antiarrhythmic in medical V-fib? What's your first drug in medical V-fib? What is your first drug in traumatic V-fib? First drug.
Epi.
First drug, epi. Epi's always first drug. In trauma V-fib, commotio cordis, RONT, they still get epi first, but instead of using amiodarone, I try what first? Lidocaine. So think of it this way. Every dead person gets epi. Medical V-fib gets amiodarone. If that don't work, I can try lidocaine. Traumatic V-fib gets epi. I'm going to try lidocaine first. If that don't work, then I can try amiodarone. Eventually, I can try both of them, either way. If it's torsades, they're still going to get epi first, but what antiarrhythmic will I try first? And if MAG don't work, can you try amiodarone? Can you try lidocaine? Yep. So basically, medical is epi, amiodarone, lidocaine. If all that shit fails, MAG. Trauma VFib is epi, lidocaine, amiodarone. If all that fails, try MAG. Torsades is epi, MAG. If that fails, try your lidocaine and amiodarone. That's as simple as we can make it. Don't overthink it. Pay attention to what that registry asks you, though. First drug in VFib. First drug.
Epi.
First antiarrhythmic in polymorphic VTAC. Fancy way of saying torsades. First antiarrhythmic in a blunt
Lidocaine.
blunt traumatic injury, lidocaine. Right? First drug in PEA.
Epi.
First drug given after epi if they are a known dialysis patient in a systole. Calcium chloride. Epi still first, but then we'll give the antidote for the renal failure, calcium chloride. Right? Does that kind of make sense on our algorithms? That's our dead people. When we come back from lunch, we'll do ROSC, 12 leads, and then the actual signs and symptoms of the MI, etc. All right? Any questions over this morning?
The bicarb's indicated if it's a downtime of more than 10 minutes, right? Or 20 minutes?
Prolonged CPR.
20 minutes. We're not moving to bicarb until they've been down for 20 minutes. So let's do this. Let's say that I have a cardiac arrest. You've been with the cardiac arrest patient for 25 minutes. What drug should you consider? And that's when they'll do the bicarb.
So you give it right before you terminate, basically.
Yeah. Yeah. Is this helping you guys?
Yeah.
So it should start putting together and connecting some dots. All right. We just got to get all that information you've halfway learned and put it back together into a better picture. All right. 1 o'clock.
Really, we're stuff.